Greetings to the audience in Armenia. The first topic of our wonderful sessions is understanding portal hemodynamics in the setting of cirrhosis. Well, cirrhosis is the final stage of chronic liver injury characterized by formation of regenerative nodules and fibrosis at the microscopic level. It is a very common cause of mortality and morbidity across the globe. And the common etiologic factors for cirrhosis are viral hepatitis, alcohol, and non-alcoholic fatty liver disease or steatohepatosis. Portal hemodynamics is crucial in the progression of cirrhosis and is directly linked to the development of complications such as variceal bleeding and ascites. That is why understanding of portal hemodynamics is very important for proper diagnosis and management of these patients. Let's review the anatomy and physiology of normal portal hemodynamics. As you know, the main portal vein is formed by joining several major veins, including the splenic vein, superior and inferior mesenteric veins, gastric and cystic veins. The portal vein drains unfiltered blood from the intestinal system to the liver, where it gets filtered and passed to the systemic circulation. The portal flow is maintained by a balance between portal vein pressure and the intrahepatic vascular resistance. Please pay attention to this concept here because it is very important, the balance between portal pressure and intrahepatic vascular resistance. The normal pressure is between 5 to 10 millimeter mercury, and higher numbers are characteristic for portal hypertension. This is a graphic representation of portal system. On your left-hand side, we see the gross anatomical representation. The portal vein, about 70% supplied to the hepatic blood flow, and hepatic artery supplying about the 30%. Portal vein delivers the unfiltered blood, which gets filtered right at this interface, this sinusoids, and gets drained into the central vein right here. So a little close-up view, and you can see the sinusoids. This is where the injury happens, yielding to cirrhosis. On the far right corner, you see the magnified graphic representation of the portosystemic interface filled by the sinusoids, and this is where the filtration happens. And many pathological factors that yield to cirrhosis affect right this interface. Very important anatomical landmark, histological landmark to understand where cirrhotic problems come from. So there are some key mechanisms that yield to portal hypertension, and these are divided into structural changes that directly affect the liver structure, sinusoidal structure, forming fibrosis and regenerative nodules, this way increasing the intrahepatic resistance, and some dynamic changes, which is rather a compensatory mechanism from the body in an attempt to control the intrahepatic vascular resistance. Think about a condition when you're stepping on a garden hose. This is the analogous situation when the sinusoid gets affected and the blood is having a difficulty to get filtered. Now, the body thinks there is a problem of inadequate blood flow, and what it does, it's resulting in splanchnic vasodilation and causing more blood to go through the portal system, thus exacerbating the portal pressure. Some key mechanisms include endothelial dysfunction at the sinusoidal level. This results in impaired production of vasodilators and increased production of vasoconstrictors. And this is further worsening the intrahepatic vascular resistance. So we talked about fixed and dynamic factors for um, portal hypertension, with the fixed one being the formation of cirrhosis and dynamic ones being the splanchnic vasodilation, specifically specifically determined by increased nitric oxide production in the splanchnic circulation and hyperdynamic circulation to supply more blood to the portal system. Some graphic representation of the events that happen during portal hypertension. First and foremost, you have increased hepatic resistance at the tissue level, sinusoidal level. This results into portal hypertension. This is causing increased systemic nitric oxide production, systemic vasodilation, starting the renin-angiotensin system, the sympathetic nervous system activation, and the body is causing some ascites and hyponatremia and hepatorenal syndrome through this compensatory efforts. Eventually, you get splanchnic vasodilation, increased portal flow, exacerbation of portal hypertension, resulting in variceal bleeding. Talking about variceal bleeding, let's review some basic anatomy of this. On the left-hand side, you see the graphic representation of the portal vein. It is formed by, main portal vein is formed by two large veins, the splenic vein and superior mesenteric vein. Some smaller veins, left gastric vein, inferior mesenteric vein, are also contributing to the portal flow. Of note, inferior mesenteric vein can drain into the splenic vein or superior mesenteric vein. We learn this component of the anatomy because it helps us understand the directions and patterns of the portosystemic shunts and varices. And on your right-hand side, you have a little picture that shows the contribution of left gastric vein to formation of cardiophrenic, esophageal, paraesophageal varices. You form gastrorenal shunt, draining the gastric outflow straight to the left main renal vein. Splenorenal shunt, similar pattern. When for any reason the splenic outflow cannot drain into the main portal vein, or it's reversed, or the flow is reversed, splenorenal shunt would readily drain this portal flow into the systemic circulation. Other important varices are rectal varices, mesenteric varices, paraumbilical and abdominal wall varices, and although not depicted here, pancreaticoduodenal varices. For the purpose of clarity, let's define the shunts and varices. Shunts are anatomical communications between the portal and systemic venous structures, whereas the varices are end organ draining veins that are under very high pressure and are very prone for rupture and bleeding. On the left-hand side, you see CAT scan showing esophageal and paraesophageal varices, white and black arrows. The endoscopy is showing the submucosal structure, submucosal distribution of this esophageal varices. Some more CAT scans, image A showing engorged paraesophageal varices, some cardiophrenic varices. On the right-hand side, you see a large gastrorenal shunt. It's shunting the blood from this from the stomach to the left main renal vein. Here's the structure right here. More images of portosystemic shunts. You see this tubular vascular structure, the splenic hilum. And on the 3D rendered images, you can see that these varices start the splenic hilum and drain into the left main renal vein. The splenic vein itself is very small compared to the size of the varices. There's probably a reason, probably a mass effect or hemodynamic changes that force the blood flow through the shunt instead of antegrade direction through the splenic vein. This is called left-sided or sinistral portal hypertension. Image A on your right-hand side shows Caput medusae. These are umbilical umbilical varices, which is confirmed on the 3D rendered images. You see the varices starting from the liver and draining into the systemic veins. Common symptoms of portal hypertension are ascites, variceal bleeding, hepatic encephalopathy, and we talked about this. Ascites being a sequela of increased pressure and hypoalbuminemia, and variceal bleeding being sequela of increased intravascular pressure, portosystemic shunting, whereas hepatic encephalopathy is a metabolic sequela of portal hypertension, where unfiltered blood shunting into the systemic circulation causes increased level of ammonia in hepatic encephalopathy. We talk about complications of hepatorenal syndrome, as discussed previously, being a sequela of hormonal dysregulation and spontaneous bacterial peritonitis from bacterial translocation in the setting of ascites. There are invasive and non-invasive approaches for diagnosing portal hypertension. The invasive methods are number one, hepatic venous pressure gradient. This is the gold standard for measuring the portal pressure. It is a catheter-based technique and accurately measures the portal or wedge pressure or hepatic wedge pressure, as well as the free hepatic pressure, the gradient of which is the portosystemic gradient, with threshold number being 10 millimeter mercury, because above these numbers, we see patients developing clinically significant complications related to ascites, hydrothorax, and variceal bleeding. Liver biopsy is a very critical tool in diagnosis of portal hypertension and cirrhotic patients, but remember that this is a pathological, histological tool and not a hemodynamic tool. As far as non-invasive methods, we have Doppler ultrasound, a very critical tool to measure portal flow direction and velocities, an irreplaceable tool for surveilling portal hypertension patients before and after portosystemic shunt creations. Elastography and MRI-based techniques are used as non-invasive imaging adjuncts to assess the degree of cirrhosis and determine the extent of portal hypertension. This is a normal Doppler ultrasound of main portal vein. It is showing hepatopetal flow towards the liver. That's the normal direction of the portal flow, with mean velocities being right around 20 centimeter per second. This is an important number to remember, 20 centimeter per second. And you'll please take a closer look at the pattern of these waveforms. It has little undulations, not quite upstroking like you see in the arterial waveforms, but not quite dampened like the venous waveforms either. So somewhere in between. We see reversal of flow as the portal hypertension progresses. On this case, left-hand side, you see intermittent hepatopetal towards the liver and hepatofugal away from the liver flow, characterized by above baseline and below baseline spectral waveforms. On the right-hand side, the flow is completely reversed, and the flow is hepatofugal away from the liver. This is the catheter-based technique for measuring the hepatic venous pressure gradient. We utilize balloon catheter and place it into one of the hepatic veins. with the balloon occluded, the pressure is sensing the sinusoidal pressure right at the interface of the portal and systemic veins, and it is also called hepatic wedge pressure. With the balloon released, we sense the free hepatic pressure, and we use the gradient of the wedge pressure minus the free hepatic pressure to give us understanding about the portal systemic gradient. As I mentioned, 10 millimeter mercury is the threshold for development of clinically significant complications. In this situation, the gradient is 19. So this patient has clinically significant portal hypertension. We will talk about endoscopic and interventional image-guided approaches for management of cirrhotic portal hypertension complications. And in this spectrum, TIPS, variceal embolization, splenic embolization are very critical. We will also discuss endoscopic interventions in very detail. As far as the pharmacological approaches go, beta blockers have been shown to reduce the cardiac output and splenic blood flow. Vasodilators can be helpful in lowering the intrahepatic resistance, and pressors can be used in acute hemorrhagic settings. With all this, there are still extensive researches going around diagnosis and management of portal hypertension. Liver stiffness measurement is an important one. Biomarkers are very important factors, getting into more utility for predicting cirrhotic complications. There are trials that focus on certain novel agents that reduce fibrosis and potentially improve the portal hypertension outcomes. And last but not least, intestinal microflora association with portal hypertension. So with all this, the emerging therapies are forwarded towards novel agents, statins, and understanding statins' roles in improving endothelial function, innovative procedures, advancing complex tips, redo tips, liver transplantation, as well as personalized medicine approaches to bring the genetic and molecular profile information in the management of individual patients and specific therapies. As conclusion of this first topic, I want to emphasize the importance of understanding the portal hemodynamics and the nature of complications, the importance of interventional and endoscopic management, the ongoing research about emerging diagnostic and therapeutic approaches. But most importantly, it is about us developing these multidisciplinary boards, bringing the diagnostic radiologist, the hepatologist, infectious disease, interventional radiologists, hepatobiliary and transplant surgeons, gastroenterologists, endoscopists. This is a complex condition requiring very complex and multidisciplinary approach. And I'm hoping that today's conference is going to take us a step up and step ahead in this mission. With this, I'm concluding this talk and welcoming any questions if you have. Thank you.